Good morning, everyone. Thank you, KSOS, and thank you, sir, for this opportunity. So I'll be talking about OCT angiography in central serous retinopathy. So OCTA is a very important diagnostic modality which has got specific indications in central serous retinopathy. So when a CNV happens with CSR, it can reduce visual acuity in long-standing cases. Although it is uncommon, the incidence is only 2 to 9%. The overlap in presentation between chronic CSCR and CNV can make the diagnosis very challenging. So why OCTA? OCTA is a 3D non-invasive imaging modality which helps in visualization of retinal and choroidal vasculature, as we were hearing till now. It helps to evaluate the choriocapiillary perfusion and the extension of flow voids. It helps in detecting CNV much evidently than a fluorescein angiography. Why? Because fluorescein angiography will have already existing features from the primary diagnosis of CSCR. So over that, finding out a CNV is a bit challenging. So this is an article from JAMA Ophthalmology in 2015 where they assess the association of CNV with CSCR using an OCTA. So their major objective was to evaluate the sensitivity of OCTA in detecting CNV associated with CSCR. They found very high sensitivity with OCTA of about 100%, and in fluorescein angiography it was about 80%. And the reason that they have documented is one, that CNV in CSCR, there are fine vessels below the RP, between the RP and the Brooks membrane, which can be picked up in an OCTA, which is not usually picked up in a fluorescein angiography. So when do we consider doing an OCTA in a case of CSCR? CSCR patients who present above the age of 50 years. Frequent recurrent disease. In frequent recurrent disease, the persisting subretinal fluid might be because of the underlying CNV. Bilateral peripapillary disease. Many a times, peripapillary disease, clinically it presents as neurosensory detachment, but there might be an underlying PCN which is missed. And there are specific OCT biomarkers which will tell us to do an OCTA in CSR, which I'll be dealing. So this is my first case, which is a 60-year-old female who presented with left eye blurring of vision and metamorphopsia for 2 years. Vision was 6/9 in left eye. As you can see, there's a neurosensory detachment with subretinal precipitates. An OCT done through the fovea, you can see there is subretinal fluid. There is a PED, but it is a flat, irregular, fibrovascular PED. Apart from what we usually see in a CSR case, it is not a serous PED. And you can also see that there are pachyvessels just in the subfoveal region. We performed an ICGA, which in the early sections show an abnormal vascular network. DFA done showed hyperfluorescence, which increasing in intensity in the later phases, showing a patchy hyperfluorescence. And OCTA was done through this flat irregular PED, which clearly showed an active network as described earlier by Sir. So what is the importance of a flat irregular PED in CSAR? So this is an article published in Retina where they evaluated flat irregular PEDs in CSCR, and they found that 1/3 of these PEDs in chronic CSCR contain CNVM. So it is a very important biomarker which alerts us to go ahead and look for a CNVM. This is another article published in AJO where they assessed shallow irregular PEDs in pachychoroid spectrum disease. They compared dye angiography and OCTA in finding out CNV, and they found that dye angiography many a times underestimates the presence of a neovascularization. In the study, neovascularization was found only in 29% cases of dye angiography and 95% cases where their OCTA was performed. This is another case of a 68-year-old male who presented with right eye blurring of vision at that point of 3 weeks duration. First, he was monitored, medically managed, and he had good resolution in 2 months. Again, in the same eye, patient presented with a recurrence 1 year later. That time, you can also see some RP irregularities and a subretinal fluid. That time, an OCTA was done, but there was no clear network. So that point, considering a chronic CSCR, a half-fluence PDT was done. Patient had good resolution, good improvement of vision. He remained stable for 2 years. After 2 years, in the same eye, patient again had a recurrence, but this time a change in OCT features are seen. There is a flat irregular PED with a hyper under it. When a hyper under a PED happens, you have to be suspicious of a CNV. So at this point, OCTA was done, a network was seen. So this is an active network as described in the previous presentation. So considering CNV, we treated the patient with aflibercept, good resolution was seen, and a dead artery network is seen in the OCTA, which was done after the aflibercept injection. So what is the importance of this particular case? It emphasized the need for serial evaluation and role of OCTA in elderly patients with CSCR. This patient might have converted from a CSR, acute CSR, over the years to a PCN. So if it was not followed up, then we would have missed it, and the role of OCTA as a follow-up tool. So this is the last case of a 54-year-old doctor who presented with right eye defective vision, not on any steroids. Right eye had 6/24 and 24 vision. You can see the neurosensory detachment with some yellowish material in the foveal region. This was the OCT done, which showed a pachychoroid. Subretinal fluid is there, subretinal hyperreflective material with irregular RP is seen. We performed an OCTA at this point. A very suspicious network was seen, but there were no flow signals. So patient, we went ahead with ICG and DFA, and DFA showed a clear leak. Diagnosed as a fibrin CSR, performed micropulse at the leak, and eplerenone was given for a month. 1 month later, this was a picture, there was no much change. So at that point, we just repeated the OCTA. The network showed a slight increase. Considering the increase in network, we gave 1 injection Accentrix. There was good resolution of subretinal fluid, but the fibrin remained. As we know, fibrin will take a long time to resolve, but he had good visual improvement, and this is the OCTA pre and post injection, which showed good resolution of the network. This is the OCT image after 4 to 5 months, where we can see the fibrin has also reduced considerably, and the vision had improved to 6/9 and 6. So this is the message from this case, that when there is fibrin, there's a possibility that there is an underlying CNVM, so we have to look for it. So this is a case report, OCTA findings in CMD, cystoid macular degeneration associated with central serous retinopathy. So in this report, they have documented that about 45% of eyes with cystoid macular degeneration, there was an underlying central serous chorioretinopathy. And this study, they evaluated the OCTA findings in fellow eyes of patients presenting with CNV associated CSCR, and 1/4 of fellow eyes showed vascular network. So it highlights the importance of imaging both eyes of chronic CSCR for early detection of CNV using OCTA. So to conclude, OCTA helps in early detection and prompt treatment of neovascularization in CSCR. FIPED is a very important diagnostic marker. This imaging modality is superior to other methods in terms of non-invasibility, reliability, and quickness. Thank you.
Thank you, Dr. Juhy.